Hey, and did you know I'm currently accepting new patients in New York, offering both in person and telehealth visits? And I also provide telehealth for patients in Michigan, with North Carolina coming soon. And I also offer coaching, both intimacy coaching and menopause coaching, nationally and internationally. So look us up on www.femvhealth.com. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about Alzheimer's and midlife. But before we get into it, the first thing I want to make very clear, I'm not giving any type of medical advice. If you have any questions about your health, make sure you go speak with your healthcare provider. And if you have any questions about your religion, make sure you go speak with your friendly neighborhood religious leader. This is a Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I'm super excited to have on with me Dr. Ashanthi. Dr. Ashanthi, if you could please go ahead and introduce yourself to the viewers and listeners out there.
Well, thank you, Sadaf, for having me on the show to talk about a really important topic for everyone in midlife, but women in particular. I'm Ashanthi Gajaweera. I'm a board certified neurologist. I have a brick and mortar practice in Rochester, New York, but I see patients throughout the state virtually. And my focus in my practice is on dementia prevention and cognitive longevity. And I hope that we get to talk more about how that is most important in midlife, contrary to how most people think about it.
Yeah, absolutely. Well, I'm so glad you are here. And well, let's just get into it. So, what drew you to the field of Alzheimer's and dementia prevention?
Well, so trained as a neurophysiologist, but
Oh,
quickly, after training, I started in private practice and I'm a general neurologist. So 23 years in general private practice neurology, you see thousands, if not, close to 10,000 patients with neurodegenerative diseases. And it became quite evident that this is a growing epidemic. And, in fact, 56 million people worldwide have a dementia diagnosis. And every 3 seconds, someone is being diagnosed with dementia or develops dementia. So this is a out of proportion chronic disease that is going to quickly overwhelm us. And for me personally, I was 46 when the first Lancet Commission publication came out in 2017. And that stated that 30% of dementia cases are preventable by addressing modifiable risk factors. And then in 2020, the next Lancet Commission came out and it said 35% of dementia cases are preventable. And then the most recent in 2024 states that 45% of dementia cases are preventable. And as I got older and I looked at my own family history, which is full of dementia, specifically vascular dementia, I wanted to do something about it for myself. And as I realized that this space is not tapped, not really something that we do in traditional neurology, and not something that is widely embraced by the general medical profession, not because of lack of data, but because of lack of infrastructure. I decided, you know what, this is what I want to do. I had a bee in my bonnet, and it was something I had to do. I couldn't not do it, in fact. So it became something I really dug into initially for my own personal well-being. And then now, my practice mission is really to try and make dementia prevention care mainstream. So it's kind of feels inevitable, and it feels like the right thing to do at this time of my life.
that's fantastic. So, you talked a lot about, really quick, I just want to go back to a little bit something that you said that in the most recent Lancet update, you said that 45% percent of Alzheimer's dementia is preventable. Can you speak a little bit more about that?
Yeah, so the Lancet Commission is this huge multidisciplinary body of work that puts out statistical data, looking very rigorously at multiple studies. And they started their first commission on dementia prevention in 2017, and then the most recent in 2024. And they've identified 14 modifiable risk factors that, if addressed, would account for 45% of dementia cases. In other words, if you were to eliminate those 14 modifiable risk factors through the population, nearly half of dementia cases would be prevented. Now, what's really interesting is that because of the rigor of their studies and the work that they're doing statistically, that doesn't include things like sleep. It doesn't include nutrition. It doesn't include sex or menopause. It doesn't include caregiver burden. It doesn't include, vaccination or all of these things that we know are actually factors in dementia prevention. So most experts do believe that, in fact, the numbers are much greater and that the majority of dementia cases are preventable. So that's once you know that, I think, frankly, I felt angry. I felt upset that we weren't doing more, which is why I thought, I need to be part of the solution rather than just being upset that the system isn't figuring this out for us.
Hmm. So, what are some of the things that they say that you can do to prevent dementia?
Well, so the 14 modifiable risk factors set by the Lancet Commission they're stratified into age. So the ones in early life, the one in early life is early education and increased education. And then midlife, which is considered age 30 to 55, I believe, there's 10 within that framework. And those are, I'm going to read them off because I always have to look at them because just in case I miss one, I don't want to feel like anybody's left out. Hearing loss, hypertension, elevated lipids, traumatic brain injury, diabetes, excessive alcohol, what did I miss? Smoking, obesity, depression. And then in late life, it's physical inactivity, social isolation, air pollution, and vision loss. So I think these are really useful. Like when you hear these 14, it's useful to understand that these are important. But I think the problem with just listing 14 things like this is we all know that those are important, right? And it comes back to what, as a neurologist for decades, I was telling my patients who would ask me, how do I prevent this from happening to me when I'm watching my parent go through this? I would say, eat better, exercise more, sleep more. But that's not really, it's not incorrect. Those are correct, but it is not helpful, right? So just telling somebody to do those things is kind of giving them a vague direction without giving them the strategies or the objective things to follow to work on those. And we can do so much better. And I think the information is out there. Every day there's more and more data in terms of what we can do for dementia prevention. And it's just a matter of putting it in a framework that is accessible to people.
So, I think you mentioned this a little bit. And so many people assume that Alzheimer's is largely genetic. How much of our risk is actually within our control?
Yeah, so I think that for many people, many patients of mine will feel like my mom had dementia. It's just a matter of time till that happens to me, or one of my siblings is sure to have it, and hopefully I'm just the lucky one. But in terms of Alzheimer's specifically, and there's many types of dementia, but Alzheimer's is the most common. In terms of Alzheimer's specifically, genetics plays a small role in terms of being a deterministic gene. So we have deterministic, genes, which means if you have that gene, you are going to have the disease. And then we have non-deterministic genes that mean that there might be some, they might play a factor, they might potentiate the disease process, but they don't necessarily mean you're going to get the disease. So in Alzheimer's specifically, less than 5% of Alzheimer's cases are truly deterministic. 95% are very much in our control. And if we start early, meaning in midlife, starting 40s, 50s, even earlier, depending on your family history and risks, you really can do a lot to mitigate your personal risk.
Yeah, so I love how you make that distinction between dementia and Alzheimer's is just a form of right one type of dementia. So maybe you could list for us, like, or at least just tell us the difference, just so that we're all on the same page.
So I think what's confusing is in a way is the definition of dementia is very vague. So dementia just means a process by which there's a decline progressively in cognition over time that affects one's daily living.
Hmm.
And that's really
That is
vague.
very big.
I
Yeah,
mean, for neurologists, especially who really like to localize and get precise, I just find this such a vague definition.
right.
And the reason is, comes back to the complexity of the brain, and hopefully we can get to that. But the Alzheimer's is the most common type of dementia, comprises about 60 to 70% of cases. The second most common type of dementia is probably there's probably evening out between Lewy body dementia and um, vascular dementia. And then there's other types like Parkinson's related dementia, uh, frontotemporal dementia. Then there's the more, I'm going to say, somewhat more rare types of dementia like multisystems atrophy and the other entities that, unless you're a neurologist, you don't probably hear of too often. But for the most part, the most common types of dementia are Alzheimer's, vascular dementia, frontotemporal dementia, and dementia with Lewy bodies, which can be the umbrella of Parkinson's or Lewy body dementia.
Yeah, I guess I didn't know there were so many different types of dementia. I guess you just hear about Alzheimer's the most.
Right.
And so tell me a little bit about the vascular dementia. Is that when somebody like has a stroke or there's some type of insult to the brain?
Yeah, so I think I said at the beginning that my family, for example, has an extensive history of vascular dementia.
Right. Hmm.
And so when we think of Alzheimer's, we in general, how we are identifying these different types of dementia is by the pathology that they present with on biopsy or autopsy, right? That's how we've traditionally thought about them. That doesn't necessarily speak to the mechanism of how they occur. It speaks to what we see on tissue sample. And where that falls short is many of these processes actually start from the same place or have common threads in which they then end up predominantly looking like one type of dementia or another. But in most patients, we actually see a lot of overlap. So vascular dementia and Alzheimer's dementia often overlap. Alzheimer's and frontotemporal dementia often overlap. So there's a lot of, it's very rare that you're going to say that there's one single form of dementia unless it's one of the more deterministic early onset dementias. In most older patients, there's going to be a lot of overlap. In terms of vascular dementia, it is that profile often does look like a patient who's had either strokes or subtle strokes. Many times, most neurologists will tell you that when you look at brain imaging of I'm going to say older individuals, I mean really anyone over the age of 60, you start to see changes in the brain that represent chronic ischemic vascular changes that may or may not be apparent clinically. And when those accumulate, they can start to take a toll in terms of resulting in a cognitive loss. And that gradual cognitive loss over time, which can be stepwise. So rather than a slow general curve, a general gradient, it'll be a stepwise course, more typically in vascular dementia, not always. That is what vascular dementia looks like. So for many people, vascular dementia risk factors are hypertension, diabetes, obesity, metabolic disease in general. But in all of the dementias, those are risk factors, right? So even for Alzheimer's dementia, um, those risk factors, those cardiovascular, metabolic, inflammatory, hormonal risk factors, all of these apply because even though we think of them as these different entities, they often have it's a very multifactorial process in terms of what gets you there over time.
Hmm. This is a little bit, you said you talked about some of the modifiable risks for dementia, and you mentioned hearing loss. And I worry about, like this newer generation of kids that always has like AirPods and, like earphones on all the time, right? I mean,
Yeah, yeah,
I tell my kids, I'm like, I
yeah.
don't know, are you like a telepro like, what is going on? Are you answering a phone? Are you on call? Like, why do you
Right.
always have that on you?
Absolutely. Yeah,
It's
yeah.
ridiculous. And so
So,
I worry about their hearing. Yeah.
yeah, I think it's a great question. Now, I have talked to some ENTs and audiologists about that because, I have a 19-year-old who's got his earbuds in all the time as well. And
Okay.
what they tell me is actually somewhat reassuring. And it's that because these more advanced headphones actually have very good noise canceling in them, and then they have the limits that they can set. I think that's what's important. And so when I actually listen to my sons, the volume feels really low to me, which is interesting, right? Because he's listening to it in the background. He's carrying on his life in general, and he's got this background noise. And one argument would be that this stimulus is actually, you might argue that this constant stimulus of low noise signal is perhaps stimulating to the auditory cortex in some ways. And I'm not arguing that everybody should have earbuds in all the time, but I think that as long as the noise level is kept down, and you can, your iPhone or your whatever phone can set those pretty quick, pretty easily. I think that's what's important. And then most importantly, I would say that they come out so that you can engage socially, because we all know, I mean, my mom is actually visiting me, and she's 80, and she's got her earbuds in all the time, and she's listening to her music, and it's so cute, but at the same time she's missing out on conversation. So I think that missing out on that social engagement with the earbuds in is more of a problem to me than the actual noise of the earbud. So
Hmm.
that's the part of it I would want to emphasize is maintaining that social engagement.
I'm still not going to tell my boys what you just said.
No, no, for sure, for sure.
I'm going to tell them to keep those things out of their ear.
Yeah,
So, okay, back to women and menopause and brain health. So,
yeah.
let's talk a little bit about that because, I'm sure that probably way better than I do that, we're talking about Alzheimer's and we talk about like midlife and menopause and all of that stuff and how, women have an increased likelihood of Alzheimer's as we get older, as we see women in postmenopause. And now we're seeing more people talk about how perhaps Alzheimer's is really a disease of midlife that starts to present in midlife and then gets worse later on. And so the inflection point of that is really the perimenopause going into menopause and the decline in estrogen. What would you say about that?
So this is a complicated topic, and I think you touched on some important things. So I'm going to step back for a minute and talk about dementia starting in midlife in general. And what do I mean by that? Because when you hear that, it's incredibly scary, right? So I'm 55, and is dementia happening in my brain? Like, what does that mean? So what do I mean by that? So uh, we now know that the biological changes, the physiologic and structural changes that occur in the brain in a patient diagnosed with dementia, those changes typically start decades before symptom onset. So if we think of the average age of diagnosis around age 80, we now know that the changes in the brain actually started in the 50s and 60s. Symptoms may only present in the 70s. In fact, I would generally tell my patients who came to me with a who came to me and I diagnosed them with dementia, I would tell them and their families that there were probably subtle symptoms starting about 10 years prior, but because our brains are so resilient and adaptive, and we are able to compensate for those symptoms. And so they only come to affect our daily life and meet that criterion for a dementia diagnosis by the time that they are severe enough. So let's just go back. 80 is diagnosis, for example, symptoms probably starting subtly in the 70s, but changes in the brain we now know occur in the 50s and 60s. So for women, well, for men too, there's andropause, but for women, there's menopause. And that's what coincides with this time frame. And we know that women comprise about 2/3 of dementia cases. And some of that is probably because we live a little bit longer. But statistically, we also know it's not purely accounted for by that longer lifespan. There's something about being a woman that increases our risk of dementia significantly, probably about 30 to 50% increased risk of dementia amongst women compared to men. So, what is happening in midlife in women is menopause. And yes, there's this dramatic upheaval and flux in perimenopause of hormones with estrogen and progesterone up and down, and then finally declining significantly to very, very low levels. And we also know that the brain is full of estrogen receptors. And many of these estrogen receptors are in the areas of the brain that are affected in Alzheimer's dementia, for example. So, on the one hand, we can consider that maybe this loss of estrogen and in areas of the brain that are crucially filled with estrogen receptors is part of the process that evolves into an Alzheimer's-like pattern. But I'm going to argue that we also know that in most women, there is actually an uptake in estrogen receptors. And in fact, after menopause, so postmenopausally, we see an increase in the number of estrogen receptors. So our brain is incredibly adaptive and incredibly able to become resilient. And in spite of menopause, and I'm going to say even because of menopause, it is able to adapt into an entirely new kind of brain. And I'm 55 and I'm about 3-4 years post-menopause. And I do feel like I have a very different brain than I did 10 years ago. And the process to get here may not have been fun, but I actually like my brain today better than my brain 10 years ago. So I'd love if we could reframe menopause as a period of neuroplasticity, just the way we think of early childhood and adolescence and young adulthood. I mean, we usually think of these as those periods where we see the most growth, the most, we protect our children, we protect our young adults. We want them to be taking care of themselves and shaping their brain and their neuroplasticity as best as possible. And I would love if women would understand that this transition is just a neurologic event that we can shape because our brains are incredibly adaptable if we give them the tools to do that.
So when you say that the number of receptors of estrogen goes up in menopause, right, in
Yeah.
postmenopause, So, are we saying that the brain is seeking out more estrogen, or it's just making it so that if there's estrogen around, it's easier for it to attach to the brain?
Yes, so that's the theory. We don't know for sure. So this data about the increased number of estrogen receptors came out just about a year ago, and the actual, why the brain decides to do that is uncertain. But the thought is that it is because of the loss of estrogen, but the importance of estrogen to the brain, that we go through the very energy greedy process of producing a receptor. I mean, producing an estrogen receptor is a lot of work, and the brain is extremely frugal in spending energy, right? Because it's already an energy greedy organ. Our brains consume 20% of our body's energy at any given time. So to then go and spend that energy on making an estrogen receptor means that it's doing something really, really important. So yes, I think it's in order to get as much estrogen as we have available. And it does then steady out. So if you look at, for example, energy levels, which in the brain, which we know are very estrogen dependent, there is this decline initially in perimenopause, and then it starts to increase and it steadies out. So where I'm going with this is that there is this initial flux and period of chaos with which feels like a decline. But if you can focus on yourself and you're optimizing your health, you can create the brain that you want to. Similar to how I would say we make sure that our adolescent, just like you said with the earbuds, right? You want to make sure they're doing everything they can to be as brain optimized as possible during that crucial window. We don't want to wait till it's too. We don't want to wait till the the brain has missed this window of neuroplasticity. Our brains stay able to create new neurons and create new synapses throughout life, even into our 90s. That's possible. I just think that menopause, we need to reframe as this period of crucial neuroplasticity, just like we do adolescence and early childhood.
That's so fascinating. I'd love to talk a little bit about brain fog, right? I mean, like that is one of the biggest symptoms that
Yeah.
we had in perimenopause and menopause. And so many women, come to me talking about brain fog. I myself have brain fog for sure. I mean, there'll be times I'll be like, what the heck was I just talking about?
Yeah.
So it's awful. But like, how do you reframe that for women? How can they tell if this is just something that's hormonal that hopefully will level off and get better, just as you were talking about this neuroplasticity time, right? During perimenopause, menopause, and then into postmenopause, or if it's something that they should really be worried about, like, is it, early onset dementia? Should I be worried about, like, how can they tell the difference?
Yeah, so, for years, I will say I saw so many women with brain fog, and they'd come to me and they would say, I was driving to my daughter's school and I ended up at my son's school. Or was taking out the garbage and I realized I hadn't put the garbage in the garbage can. So there are, I think for years I heard this and I just thought, you just have a lot on your plate. Your life is stressful. You're in the sandwich generation, depression, anxiety, and many of them had already been given an SSRI from their doctors. And so I think the first thing is to recognize that this happens and to cut yourself some slack for it. Your brain is really going through a lot. And just like you cut some slack for your crazy teenager, cut yourself some slack for yourself because just like their brains, your brain is going through a tremendous change. So just like your teenager, though, you need to take care of it. And so that's the sleep, the nutrition, and the movement and exercise. All of those things are important. In terms of trying to figure out the difference, well, brain fog typically feels like something that you know about. You are able to mask, but you are just hyper aware of, because in your own mind you are glitching. That's what it feels like. You are trying to say something, you suddenly lose track. You are going somewhere and you take the wrong turn. But you are aware of it and you're able to correct for it. Something like an early onset dementia generally is much more progressive, persistent, and in all domains. It doesn't mean that there's no overlap. I've certainly seen patients who ultimately did end up being evaluated for early onset dementia. But at least generally speaking, the difference is one is more intermittent and the other is more persistent and pervasive in all domains of life and more obvious to other people as well. Now, I would say if you're not sure, get evaluated, right? Because an astute neurologist should be able to help you define that better. I will say that I think in general, neurology tends to be increasingly siloed in its care. So, like I said, I practiced as a general neurologist, but so that means I saw everything from migraine to epilepsy to dementia, Parkinson's, and MS. In one day, I got it all, which was actually so much fun to be able to sort of be stimulated and help all of those different types of issues. But generally, more increasingly, neurology is siloed in I'm a migraine doctor, I'm an epilepsy doctor. So, what that means is there's very few who are going to be menopause specifically trained. I believe I'm one of the few, I don't know any others. I'm going to guess that there are more. I'm one of the only Menopause Society certified practitioners who's also a board certified neurologist in the US. I'm hoping I'm not the only one. If you're out there, I'd love to meet you and chat. But I think neurologic evaluation, sometimes imaging, and certainly cognitive testing can be helpful to help you determine the different kinds of issues that you're having.
Yeah. I actually just gave a patient of mine the number for a neurologist because she was worried about early onset dementia. And she had had some traumatic injury to her frontal lobe when she was
Yeah,
younger.
yeah,
And
yeah.
so she was, she's really worried. So, what does the research currently tell us about hormones and dementia? You mentioned a little bit about the estrogen receptors and the increase in postmenopause, but does it say that estrogen is helpful? I mean, we'd like to think that estrogen is the answer for everything, right? At least I do, but but that may not be the case.
Yeah. So there let me just say that there's not an FDA approval for hormone replacement therapy for dementia
Correct.
prevention or for
Absolutely.
cognition. Um, but having said that, if you are an individual who is in the midst of brain fog or sleep deprivation or hot flashes, then targeting those symptoms is likely to help with your brain fog, right? So targeting the sleep is likely to help with the brain fog. Targeting the hot flashes is likely to help with the brain fog. So targeting the mood swings is likely to help with the brain fog. So the way I approach it is what am I objectively trying to improve when I'm addressing this for future dementia prevention? Now, in terms of the randomized controlled trials, as you well know, I'm sure that there's been limited trials, and those looked at different formulations of asymptomatic patients who weren't having hot flashes, for example. And in those trials, there was no benefit in dementia prevention. In fact, there might have been some increased risk of dementia, especially in older individuals. and especially on those on a combination of estrogen and progesterone, but it was synthetic formulations in much higher doses than we use typically today. In observational studies, more recent observational studies, and looking like at a meta-analysis of these, about 32% decreased risk of dementia in those on estrogen alone, and about a neutral response to combined estrogen progesterone. So what I do is I encourage women to to talk to me about what symptoms they're trying to address. And then we address the symptoms with menopausal hormone therapy. And in the right individual, that is absolutely the correct thing to do. But I do think we need to have a more nuanced view if we're thinking about it from a dementia prevention standpoint. For example, we now know that women with increased hot flashes, especially nocturnal hot flashes that they may not even be aware of, have increased burden of white matter lesions on imaging. And we know that white matter lesion increased burden is related to increased dementia risk. So if I, for example, see a woman with brain fog and hot flashes and white matter lesions on imaging, if she otherwise fits the profile correctly and without other significant risks, she may be somebody that I am more likely to encourage that she consider menopause hormonal therapy.
When you talked about the research, you said something about estrogen decreasing the risk, right? And combined hormones having a null effect. Was there a difference in synthetic estrogens and versus body identical hormones or synthetic progestin, right?
Yeah, so the randomized control study, so the WHI
The
and the
WHI.
WHIMS and the WHIMSY, which is the younger patients and mental status, those individuals, that was all with the synthetic.
Synthetic.
Yeah,
Hmm.
and then so the observational studies were in those with body identical or bioidentical hormones for the most part.
Okay.
It was a meta-analysis, so but it was I don't remember the earliest, but I think that came out in 2024 and looked at observational studies, probably from like 2014.
So if you're able to address some of the symptoms, that may help somebody to decrease their risk of Alzheimer's. Am I understanding that correctly? So you were talking about hot flashes. You're talking about the sleep disturbance. I mean, sleep disturbances was one of the modifiable risks, right? You were talking about before.
So sleep
So,
disturbances isn't actually in the Lancet Commission's
uh
list of modifiable risks, but we know that poor chronic insomnia significantly increases your risk of
okay,
dementia. Yeah.
okay, all right. So you're saying that if you take care of some of the symptoms in menopause, could that potentially help? What would you say would decrease the risk or of dementia, or do you think it would delay the onset? I mean, I don't know. You had also mentioned that some of it is genetic, but not all of it, right? Determinant genes
Yeah, so
and
I think just to step back, the way I approach it is a very much of a risk profile. So
mhm,
um, in my practice, what I do for dementia prevention is a longitudinal program over about a year. And the beginning of that is we identify your risks. So risks are ancestry and genetics for sure, whether that's a deterministic or non-deterministic gene. The most common non-deterministic gene is the ApoE4 gene. So looking at that genetic profile and determining risk. So age, sex, genes. We can't control those. So we start with that, right? So that's the first thing. And then the next is looking at objective measures of the other things that we know factor into dementia risk. And because our brain is downstream of everything else we do, That is whole body health. So I'm a neurologist, but I'm going to be checking, your cardiometabolic health, your vascular health, your inflammatory health, your hormonal health, your gut microbiome. So looking at all of that from the lens of brain health downstream. So what we might say is okay or normal from a pure diabetes standpoint, for example, or from a pure lipid standpoint, is going to be very different and perhaps a much more critical lens when we're looking at it from a dementia risk standpoint. So once you figure out your risk profile, including hormonal health, right? If you, for example, are a woman with late menarche, onset of periods, but early menopause, then you have an increased risk of dementia based on that shorter hormonal reproductive lifespan. So in that individual, it may be more important to start hormone replacement therapy. But it's a so it's an individualized conversation, and I can't tell you that it's every person should be on one or the other. Really depends on weighing those uh, all of those risk factors and deciding where to focus your energy. Because there's a million things, not just hormones, right? There's literally, if you're interested in cognitive longevity and brain health, every day there's a new study about what you can be doing, and there's just too many things to do. And if like if you're like me and you like the 80-20 principle, you put the 20% of your energy into the things that are really going to move the needle, and that for you may be different than it is for me. So in one person that might be hormone therapy, but in another person that might be really vigilant lipid management. And in another individual, that might be improving visceral fat, for example. So it's really a question of objectively trying to stratify our risk factors and then focus the energy as best as possible, because we only have so much time and resources.
Yeah. So, are there any particular lifestyle interventions that you would recommend for, let's say, midlife women to help with if they're really concerned about dementia prevention?
Yeah, I think the one that we struggle with the most is probably sleep, and I can say for myself that that's the big one. But it really is the foundation, and once you have that one, you can build on it, right? So sleep, I think, optimizing our sleep is the most important, and um, there's so much we can do, and yet sleep in itself is so anxiety provoking, because when you don't sleep it makes you feel anxious, and then it's just this never ending loop. But emphasizing importance of sleep, and that the majority of insomnia is treatable. So whether it's hormone therapy, whether it's cognitive and behavioral therapy, which can treat 70 to 80% of insomnias, but is probably the least utilized wonderful tool that we have for treating insomnia, whether it is sleep apnea or other types of parasomnias that we can have. Um, Increased sleep apnea with menopause is so common. Whether it's your husband snoring, whether it's just that you need really good noise canceling earbuds for when he snores, whether it's lowering your room temperature to 66 degrees. All of these are little nuggets of things that, depending on the individual, can be helpful. But if I'm going to say one thing that can help with move every lever, right? Improve your metabolic, your cardiovascular, your blood pressure, your mental health, your every lever is going to be improved if you can sleep better and more deeply and restfully.
Hmm. Yeah, for sure. I definitely need some help in that domain. But so if somebody was to, right, so you just mentioned one of the lifestyle interventions that we can take. How about, do you have other lifestyle interventions that you would recommend? So you said definitely optimizing sleep for somebody that is really concerned about dementia prevention. Would you say exercise, or what are some other things? And I know you mentioned that perhaps hormones for those individuals that want to consider hormones, that might be something that they consider.
Yeah, well, I kind of stack them. So sleep is the foundation. And like I said at the beginning, I think telling people to sleep better, exercise more, and eat better, it's correct, but it feels so empty. So I have to admit that I hesitate to even say this to you because it feels like I'm just kind of a wellness influencer and telling people sleep better. But there's, I guess the point is sleep better, but there are so many tools that if you work with the right doctor, they're going to be able to find the right tool for you. I think that it's for any of these things. So sleep is the foundation. And then the next stack on that foundation is movement, because movement and sleep compound together, right? One is rest and one is stimulation. And so your body needs yin and it needs yang. So rest is and rest and restoration are the sleep factor, but movement is the other thing that moves the needle so much. Again, it affects all of those domains of health in terms of cardiovascular, metabolic, etc. It improves all of those. And here's the thing: if you move at the right time of every day, you are going to sleep better. So movement and sleep go together. You'll sleep better if you move. You'll move better if you sleep. So those are really, I'm going to say those are the two biggest foundational stacks. I do think, nutrition and then medications and supplements are important, but those are kind of the top of that pillar. And I really think that I'm going to say put social supports actually right after movement, but or right with movement and nutrition. So I do think those are the two most important because they serve everything else to work better. It's really
Hmm.
hard to tell somebody to, eat a whole food plant-based diet with along with fatty fish and get this many grams of fiber and this much protein and to tell them to make sure they're getting all their phytonutrients if they have not slept. Like you can't do any of those things properly if you haven't slept well. So I think that's where the sleep and the movement and the moving is going to make you want to eat better. It's just what your body asks for, right? If you are moving and really maximizing that, your body will ask you for better food. My son, my 19-year-old's a junk eater all his life, but he's training for a triathlon in July. And boy, I have never seen this kid eat better than I have in this past few weeks. He's like the fiber intake, the vegetables. It's pretty impressive what movement will motivate you to do.
Awesome. So you actually said something that I'm curious about. You said movement at the right time of day. What does
Yeah.
that mean? Does that mean like first thing in the morning? Probably not right before sleep, because I would assume that you
Yeah.
would be really like
Yeah. Yeah. So,
energized after working out.
each of our cells has a circadian rhythm, right? And that is mind blowing when you think about it. Chinese medicine has, and Ayurvedic medicine has known this for centuries, but we're finally catching up to knowing this too. But each of our cells has a circadian rhythm. And in our brain, that's the master clock of sorts that picks up the signals from each of our cells. But in terms of in terms of how we set that master clock is something called Zeitgebers. And Zeitgebers are the external stimulus that we then rely on to set the clock. And Zeitgebers, the most common are exercise, eating, movement, even things like social engagement. All of those are sunlight exposure. Those are all Zeitgebers. So when we expose our bodies to that, is it determines how that clock gets set. So I actually have a whole bunch of Instagram reels on Zeitgebers because I think they're really
Oh, I
fun
have to
to
look
think
at this.
about when,
Yeah.
especially when you're jet lagged. I did them all when I was jet lagged because I was trying to pay attention to my Zeitgebers. But for example, yeah, if you depending on when you exercise can help you determine the best time of sleep. And it is going to be different, a little bit different for each individual based on their body rhythm and their body clock. But for the most part, you shouldn't be doing stimulating, vigorous exercise in the evening, even though I'm sometimes guilty of doing that. But because that's when I have the time to do it. But in general, if you're trying to really set your circadian rhythm, and if sleep is really a paramount issue to you or difficulty for you, then morning to early afternoon exercise can be best for sleep, for setting that sleep rhythm with the exercise Zeitgeber.
Hmm. Well, that sounds, I'm so curious about those. Is it Zeitgeber?
Yes,
Zeitgeber? How
I
do you
think
spell it?
Zeitgeber.
I'd love to know if there was a specific type of diet that you think is good for dementia prevention. You're probably going to say Mediterranean, decrease
So
salt.
Zeitgeber is how I spelled it, Zeitgeber, and it is a German for time giver.
Oh, so
Um,
interesting.
yeah, there's a lot of really interesting work, and lots of like sleep medicine docs love Zeitgebers. And I think just as a neurologist who's interested in brain health, you have to know your Zeitgebers pretty well. In terms of diet, so this is a good question. And I think that following the Mediterranean diet or the mind diet are easy to do. And they have been shown to be beneficial. But I think it's important to also consider that one reason we talk about them is because they're easy, right? They're easy to follow. They aren't too restrictive. They work in the American diet typically. They allow for a lot of whole grains, which our food pyramid for years has been full of a lot of grains. And so the Mediterranean diet is generally one that, if I'm trying to give a quick answer to somebody on what you should eat, the Mediterranean or the Mind diet, look those up. It's the easiest one to follow and probably helpful. Now, I do think that for each individual, it's going to change, right? So for the Mediterranean diet, for me, the Mediterranean diet, if you look at that, it's full of whole grains. But for a person like myself who has, and in spite of living a very active and careful life, has a propensity for prediabetes. So for me, eating that amount of grains is not the right diet for me. So that's where that nuanced risk factor profiling needs to come in. So I know that for me, the Mediterranean, a sort of streamlined Mediterranean diet isn't going to work. For me, it's got to be more of a low carb Sri Lankan Mediterranean diet. So, sort of mixing the elements of what you would get in a Mediterranean diet, like the whole green, the whole grains when you're eating them, leafy vegetables, fatty fish, and making sure that the number of vegetables you have, the high fiber content, nuts, seeds, legumes, making all of your carbs when possible into legumes, for me would, for example, be better. But that's not going to work for everybody. So I think telling us that the mind or the Mediterranean is what is, it's what we can study because people will adhere to it, and it's also culturally accessible for most people. So it's an easy answer. I don't think it's necessarily the best answer for each individual.
I feel like we could keep going on and on and on. There's so many questions I want to ask you. And you actually brought up a very good point about, I assume, are you South Asian?
I'm South Asian. My family's from Sri Lanka.
Okay, yes. So I am as well. And South Asians have a higher risk of metabolic disease. We know that, right? With
Hmm.
higher risk
Hmm.
of diabetes, of cardiac disease, cholesterol, and all of that. So
Right.
to your point, right? Like our diet has to be different because our genetics are different and we just have a higher
Exactly.
risk of cardiac disease. So what works for some people probably will not work for South Asians. So I'm glad
Right.
you brought that. Are there connections between sexual health, intimacy, and cognitive health that you think people should know about?
Yeah, I don't know of a study, but we know that social interactions, social connections, affection, love, intimacy, all of these things are amazing for our brains, right? Like just the amount of oxytocin release that we get from any of those interactions it happens in our brain. So These are incredibly important neurotransmitters and in terms of helping with neuroplasticity. And I think that neglecting that aspect of our lives as we can start to do as we age is losing an important aspect of health that we should be focusing on, and brings joy and brings help to every other aspect as well, right? It's the brain is whenever I think about it, like the brain is your greatest common factor. Whatever's good for the brain is good for everything else. And perhaps, things something like intimacy and sexual health and love and that bonding, that's perhaps the greatest common factor too.
Mhm. Yeah. So, what do you personally do to protect your own brain health?
So, what I find most difficult, but is most important, is my sleep regimen. So, something I do is I try to sleep, which is the really hard because I'm a night owl. I try to be asleep by 11 p.m. so that I can wake up at 7 a.m. so that I have a regular routine schedule. Ideally, you would keep to that 7 days a week so that you're not in a form of jet lag on the off days that you're trying to, the weekend jet lag kind of phenomena from just staying up and socializing. So that's probably one of the main things I do. The other things that I do are I'm really vigilant about my numbers and my objectively looking at things. And that's kind of one reason I started the kind of practice I'm doing, because I realized nobody's doing the following the objective markers that I want to be following with the critical lens of brain health. I think that even when they look at them, they'll say that they're fine, but I know that I need to be more vigilant of that. So I've become much more careful in terms of following those. And then the exercise component and then the nutrition component. I married a really good cook, so I got really lucky there.
That is one of the key things, right? Is to marry a good cook.
It really, oh my gosh, yes. I might have to tell my kids that, that
Yeah.
marrying a good
What
cook,
to look
that's the
for, right?
secret to successful marriage. Yeah.
Absolutely. So it seems like if listeners remembered one thing from this conversation, you'd want it to be about optimizing sleep health. Is there anything else that you would recommend that they remember from this conversation?
Yeah, it's that your brain is adaptable, and in that adaptability lies a problem, but also a potential, right? So the problem is that it can mask things for a long time. But then the potential is that if you can seize that window of opportunity, your brain can do amazing things for you for decades to come.
Amazing. And what is one habit you think everyone should start this week?
Oh, drink more water. That's an easy one. Like love to give an easy thing, right? Your brain is 75% water. So drink water, not juice, water. And generally about I think it's 1 ounce per kilogram of weight is kind of what you want to aim for.
Awesome. And if you were to give one suggestion for a book everyone should read about their brain health, what do you think that would be?
So it's The Stimulated Mind, and it's Future Proof for Your Brain by Tommy Wood. And that just came out and is a good book. And he's a fun guy to listen to. He's a scientist clinician, so I love the combination. I really love when clinicians are actually also talking about helping people.
Amazing. Wow. This was such an amazing talk, and I feel like I need to have you on again so we can talk more about brain health, because this is one of the topics that I actually don't have very many guests talking about. So this has been such an amazing conversation. So for all those people that are listening, they're like, "Wow, Dr. Ashanthi is amazing." How can they listen to you? Where can they follow you? How can they make an appointment with you?
Yeah, so thank you. You can find me on my website. It's healthspanneuro.com, HEALTHSPAN neuro, neuro.com. You can find me on Instagram, Facebook, and YouTube at dr.gajaweera, Gajaweera. I have an evolving YouTube channel, and if you guys want me to talk about anything, I'd love to have questions or topics you'd like me to cover. So let me know. And then, yeah, that's how you can find me. I try to read every message and respond. So would love to hear from you.
And what's your social handle?
That is my social handles, dr.gajaweera. Yeah.
Awesome. Awesome. Well, thank you. And well, we are done here, and it's been real and really intimate. Remember, this is not meant to be any type of medical advice. So if you are having any issues with your brain health or health in general, make sure you go speak with your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.